Yes, thank you. So I won't be covering anything about single field analysis. It's something we can go directly into it. I won't be covering anything about single field analysis. Let's just assume that everyone knows how to read a single field analysis printout. Now, we'll try to cover whether this the perimetry is really glaucomatous or not. What about the reliability, what differentials you should consider, what test to use when, and a little bit on modern progression analysis. So visual field in glaucoma classically begins in the mid-peripheral area with a cedial scotoma going on to become an arcuate or a double arcuate scotoma. So it is generally asymmetrical across the horizontal midline. That is what we should always remember, and the location, as I already discussed. It should correlate very well with our disc findings. We have the classic criteria to diagnose a field. The important thing to remember is that the same points are there on consecutive fields. It is just not one printout which matters. For example, in this particular printout, it's perfectly satisfying the criteria mentioned previously, but 1 week later we repeat the field, and there you have the effect of the learning curve. Although the previous field perfectly satisfies it, and perhaps if it was a concentric cupping, it would correlate with that also. But then there's always a learning curve for visual fields, and therefore on 2 consecutive fields, it should be perfectly repeatable. All these defects should be perfectly repeatable. We should also look at the bottom of the chart. If you see this printout, even in the first field it was perfectly reliable. Everything is within 20. Zero fixation losses, false negatives 13%, false positives only 3%. At the bottom you have the gaze tracker, an upshoot which would indicate when the patient is looking away from the center, and a downshoot when the patient has a blink or has slept off. So even the entire length of this gaze tracker would give us an idea as to how long the patient has taken to respond. As mentioned earlier, it should perfectly correlate with the fundus picture, with the disc findings. There are multiple lesions which can produce arcuate scotomas, either in the retina, or just a BRAO or a BRVO also can produce an arcuate scotoma, or disc lesions as well as optic nerve lesions. Again, one more example wherein it's perfectly an arcuate scotoma satisfying all the criteria mentioned above, but if you look at the fundus picture, it is because of disc drusen inferiorly you get this picture. When to apply which test? Now this, we would all know that 30-2 has no value here in a more advanced field, and therefore a 10-2 field would give us a more magnified view of the central field, which would be more useful to prognosticate this case in the long-term follow-up. But also in fields like this, wherein the field loss is very close to fixation, quite deep there, a 10-2 has more value, because the central points, you need to follow up them closely with the overview analysis. And in such a patient, 30-2 alone won't be enough. For every follow-up visit, we have to do a 30 as well as a 10-2 to look at the central points too. For progression analysis, classically we used to use the overview analysis, and then try to look for new field defects as well as deepening of scotoma. There were criteria which were defined. This would be time consuming, and most practitioners would just look at the mean deviation and look at that. Only if the mean deviation had dropped a lot, then they would really analyze where the progression is there. This is one example of a progressing field. In this example, we see that the field has progressed rapidly towards the bottom, which is not classical with glaucoma. Even so in the other eye. If you look at the values there, they're visible, yes. They're all 0. It's not a relative scotoma, it is an absolute scotoma there. This can occur in a glaucoma patient if there is some concurrent CNS lesion too. So always remember, it is not only glaucoma which is causing a progression, there might be something else. The same field effect magnified. So everyone progresses. It's a matter of how fast our particular patient is progressing, what the age of the patient is, and whether this progression will have any bearing on the patient's quality of life. Which type of progression should we intervene in? Now, this particular chart is there in all our modern perimeters. The GPA summary would give this. the rate of progression analysis. Here the visual field index, something similar to mean deviation, not exactly mean deviation, which is corrected to the age of the patient is used, known as the visual field index. This is plotted against the patient's age and over the past records. Here you have all the patient's previous records, and then the slope is then determined. You have the loss till date from the baseline, projected loss over the next few years, 5 years, that is given. So we use this chart, and just an example of how this visual field index can influence the patient's quality of life. In the initial part, wherein its VFI can drop to 80, is when, especially if the patient has an inferior field defect, the patient is more prone to some falls. Once it comes below 60, it's driving difficulty. Below 50, the patient has problems in reading, and when it is below 30 is when mobility is affected. In this example, you have a small field defect here. Although it is very small, this patient may not perceive here, and then he would extrapolate that there is nothing there, while there is actually something there. Because he had that field defect, he may be missing it, and therefore mobility and driving becomes a problem. So when we have these sort of charts, trend analysis of progression, these are very useful. So in this particular patient, he is progressing slowly. His age is given against this plot, 81 years old. Over the next 5 years, he is not losing around 20% of his VFI, which may not be significant in such an elderly gentleman. But if either his age is younger or the field was progressing very rapidly, like here you're seeing that the field VFI is already 40%. The minute it comes below 30% is when the quality of life is severely affected. This is when we have to intervene in the form of a surgical intervention. With this, I conclude my talk. Thank you.